I don't know, I'm Natalie Pate, one of the OB anesthesia attendings, and today I'll be talking about anesthesia for non-delivery obstetric procedures. Okay, I have no disclosures, and we'll be discussing the background and indications for cerclage, external cephalic version, and postpartum sterilization, some anesthetic considerations, as well as evidence supporting those considerations for these procedures. I know not all of you go up to labor and delivery, but as our volume continues increasing up there, it's certainly possible that some of these procedures will start being done in the main operating rooms at times. So hopefully it feels somewhat relevant for everyone. So a cerclage is a cervical suture placed to prevent cervical shortening and subsequent pregnancy loss or preterm delivery, performed for patients who either have a history of or a risk of cervical insufficiency, which is painless cervical dilation after the first trimester. It can be performed transvaginally or transabdominally. Most are done transvaginally, and that's what I'll be referring to for the rest of this section. The American College of Obstetricians and Gynecologists has 3 buckets of indications for a cerclage, and that's either history indicated, ultrasound indicated, or emergency. History indicated would be someone who has a prior history of cervical insufficiency and pregnancy loss, and this is usually done at the end of the first trimester. Ultrasound indicated is if someone has ultrasound evidence in this pregnancy of cervical shortening and a history of a prior spontaneous preterm birth. And then emergency, which is also called exam indicated or rescue cerclage, is when someone comes in with preterm cervical dilation. Cerclage has been shown to help keep patients pregnant, so there's decreased risk of preterm birth before several different gestational age time points and reduces the risk of perinatal death, although it doesn't seem to significantly change rates of neonatal morbidity. There are some risks, including rupture of membranes at the time of the procedure, intraamniotic infection, and cervical lacerations, but these risks are overall uncommon. When we think about anesthesia for these procedures, first and foremost, we want to provide adequate analgesia, of course. We also want to minimize increases in intra-abdominal and intrauterine pressure, especially in the cases of rescue cerclage, to prevent further bulging and possible rupture of membranes. In patients who are having this done at or after around 20 weeks gestation, we also think about providing left uterine displacement and aspiration prophylaxis. These are short procedures, like less than 20 minutes or so of actual operating time, so we really only need a brief duration of anesthesia, and patients generally go home afterwards, so having an anesthetic with rapid recovery is also desirable. We can either provide neuraxial or general anesthesia, and most times we're opting for neuraxial for that consideration of limiting any fetal anesthetic exposure. We're also, by providing neuraxial anesthesia, avoiding maternal airway instrumentation. We can see decreased nausea and vomiting and no postoperative sedation compared to general, since we're not giving any systemic medications. And if we do neuraxial, we do need sensory blockade from T10 to the sacrum in order to fully cover our cervical, vaginal, and perineal innervation. One benefit of general anesthesia is that our volatile anesthetics relax our uterine smooth muscle, which is something that's a problem after our cesarean deliveries, but something that's actually desirable in this case. We do tend to see faster PACU recovery and less risk of delayed voiding compared to the time it takes for a neuraxial anesthetic to resolve. And because this is done between sometime at the end of the first trimester through mid-second trimester, we don't necessarily need to intubate patients depending on their gestational age and other comorbidities or concerns. There's no evidence for a difference in outcomes from our anesthetic choice of neuraxial versus general, though there's also no large randomized trial comparing the two. There was one small RCT comparing spinal with general for elective cerclage that did not detect a difference in fetal loss or preterm delivery, but it was underpowered to do so. A retrospective multicenter cohort study of almost 500 patients assessed perioperative outcomes as opposed to pregnancy and fetal outcomes, and it only showed a difference in having increased analgesic use in the PACU after general anesthesia, but there were no anesthetic complications in either group. And a case control study of about 300 patients presenting for a rescue cerclage receiving either spinal or general showed no differences in maternal or neonatal outcomes, miscarriage, or preterm delivery. We'll spend the rest of this section discussing evidence for management of neuraxial anesthesia, and the default for a long time has always been to use bupivacaine, and there are several papers from the last few years investigating the use of chloroprocaine as an alternative and the adequacy of both options. These studies are centered around the anesthetic goals we discussed earlier of providing effective surgical anesthesia with rapid postoperative resolution to allow for prompt discharge after a short procedure. So this first study is an RCT from Columbia published in 2022 comparing 50 milligrams of 3% 2-chloroprocaine versus 9 milligrams of 0.75% hyperbaric bupivacaine with 15 micrograms of fentanyl in both groups. Their primary outcome was time from spinal injection to motor block resolution, and the main secondary outcomes were time from spinal to reach a T12 dermatomal level, have resolution of sensory block, and to ambulate and void, which is generally kind of the last thing patients need to meet after neuraxial before they're ready for discharge. They found no difference between the groups in the primary outcome, with just under 2 hours for motor block resolution in both groups. Patients in the chloroprocaine group did have a significantly shorter resolution of their sensory block by over 50 minutes and with a more predictable time to resolution, and they reached discharge readiness almost 80 minutes earlier than the bupivacaine group. So this study suggested that 3% chloroprocaine may be a more favorable intrathecal local anesthetic for cerclage compared to bupivacaine because of earlier postoperative discharge with similarly effective surgical anesthesia. This next study, also from 2022, was a prospective multi-center clinical trial involving the University of Arkansas and Duke. This was a dose-finding study to determine the effective dose for 90% of patients of intrathecal chloroprocaine with 10 micrograms of fentanyl for elective cerclage. An effective block was considered reaching at least a T12 block height and requiring no epidural or IV supplementation during the procedure. They also looked at a number of secondary outcomes, including time to resolution of motor and sensory block, discharge readiness, anesthetic side effects like nausea, vomiting, and pruritus, and patient satisfaction with anesthetic care. They used this up-down sequential allocation with a biased coin design, which meant the first patient received a dose of 45 milligrams. If that dose failed, the dose would definitely be stepped up for the next patient, and then if the dose was successful, there was a 1/9 probability of the next patient receiving a lower dose and an 8/9 probability of them receiving the same dose. So this graph here just kind of shows the way that patients were stepped up or down depending on success or failure of a dose. Through this, they determined the ED90 to be 49.5 milligrams. So this was nearly identical to the 50 milligram dose in that prior study we just discussed, which that had just been pragmatically selected, but it kind of happened to match what this found as the ED90. There were 3 total patients who experienced intra-op pain despite having achieved at least a T10 sensory level by the start of surgery. And there was no significant difference in sensory or motor block resolution between the patients who received the lowest doses of chloroprocaine versus the highest doses. But interestingly, both of these were quite a bit faster compared to the study we had discussed first, despite using a nearly identical average dose of chloroprocaine. And both groups had nearly the same time for readiness to PACU discharge. So it's possible it was just related in part to what they were using as their exact metrics to consider resolution or discharge readiness. But overall, this study also supports a dose of 50 milligrams of chloroprocaine with 10 micrograms of fentanyl for spinal for cerclage. Another study, the last couple we'll discuss were all retrospective studies, but this one analyzed 360 patients who had a spinal and received either bupivacaine or chloroprocaine. The median doses were a little bit less than what we've discussed from those earlier trials, and most of them did include intrathecal fentanyl. And they similarly support that chloroprocaine may reduce the time to discharge while providing comparable anesthesia to that of bupivacaine. Another retrospective study published just last year from Northwestern kind of further emphasizes the faster discharge readiness and comparable analgesia between the two local anesthetics. This study also pointed out that doses of chloroprocaine that were greater than versus less than the estimated ED90 didn't have a big difference in their time to discharge readiness. So these authors suggested that maybe a higher dose would help decrease the rate of any intraoperative pain or failed anesthesia without significantly changing the time to readiness for discharge. And this last study had been from the group from Columbia who did that original trial comparing bupivacaine and chloroprocaine. They had found about a 9% rate of intraoperative discomfort with chloroprocaine, and their group decided that was too high and instituted a practice pattern to have all patients receive 60 milligrams of chloroprocaine for their spinals. So this was about 200 patients over 2 years of experience with that higher dose. There were no safety concerns with the higher dose, and there was a trend towards lower anesthetic supplementation, although this did prolong discharge times by about half an hour. So contrary to the study I just mentioned where they didn't find a difference in discharge time with slightly lower versus slightly higher doses of chloroprocaine, this one did suggest it may be prolonged. But keeping in mind that these are retrospective studies, so we really would need an adequately powered prospective study to assess the effect of this higher dosing. So in summary, a cerclage is a procedure usually performed during the second trimester based on history, ultrasound, or exam. General or neuraxial anesthesia are safe options, although we usually prefer neuraxial anesthesia to avoid anesthetic exposure to the fetus and to avoid maternal airway instrumentation. Bupivacaine or chloroprocaine are similarly effective and safe, and based on the studies we just reviewed, reasonable dosing is about 7.5 to 9 milligrams of bupivacaine or 50 to 60 milligrams of chloroprocaine using 10 to 15 micrograms of fentanyl as an adjuvant. I do personally prefer using chloroprocaine just because I like knowing that I will have faster discharge with similar anesthesia and analgesia during the procedure, but either is definitely a reasonable option. So we'll move on to talk about external cephalic version, or ECV. As many of you probably know, this is a procedure used applying pressure to the abdomen to try and turn a breech baby to a cephalic or vertex position. Stats from 2023 are that about 4% of fetuses are breech at term, and overall less than 10% of patients with a breech fetus attempt an ECV, and about half of those are successful. Most breech babies are delivered via cesarean, so a successful ECV offers the chance to avoid a cesarean delivery with its associated morbidity, and therefore also prevents the need in future pregnancies for a repeat cesarean delivery or a trial of labor. ACOG recommends offering an ECV as an alternative to planned C-section for a term singleton breech fetus. And a Cochrane review on ECV for breech presentation at term, which was last updated in 2015, supports that ECV increases the likelihood of a head-down presentation at delivery and the likelihood of achieving a vaginal birth, and hence decreasing the rate of cesarean delivery without increasing neonatal morbidity. There was a systematic review in the early 2000s that had over 7,000 patients assessing version-related risks, and they concluded that risks were low and that ECV is a safe procedure overall. The most common abnormality is transient abnormal fetal monitoring patterns, although we rarely see persistently abnormal fetal monitoring necessitating an emergency cesarean delivery. So they found that the rate of emergency cesarean delivery was about 0.43%. I don't know the exact stats here. I would be interested to see if that's something we can figure out, because anecdotally it seems like it's probably higher than that, but still not something that is super common, but is always our concern. 37 weeks is the recommended timing for ECV because a breech baby is unlikely to turn head down spontaneously after that point, but they're also relatively mature because 37 weeks is considered early term. So if they do end up needing to be delivered at the time of the ECV procedure, they should do okay. Patients undergoing ECV can have a prior uterine scar, so it's okay if someone's had a C-section before, but they have to be candidates for a vaginal delivery, or else there's really no point. And this has only really been studied in singleton fetuses, not multiple gestation. Patients who have an ECV at 37 weeks should usually be discharged home after the procedure, regardless of whether or not it's successful, unless they have a separate indication for an earlier delivery. And a smaller subset of patients who come for an ECV at full term, maybe their baby was either found late to be breech or they want to try a repeat ECV before cesarean delivery. And in these cases, it either, like if the ECV fails, you're already in the OR and immediately proceed to a C-section, or if it's successful, then they'll get moved to a labor room for induction of labor. The intention of using anesthesia for ECV is to help increase the likelihood of success by making mom more comfortable. And Neuraxial also relaxes abdominal musculature, which in theory should make it easier to turn a breech baby. So nitrous for ECV would be an awesome option if it worked. It's non-invasive, doesn't require many resources, and has few transient side effects. So it would be an ideal option, but unfortunately, the two most recent RCTs are concordant with earlier studies that although nitrous is safe, it really doesn't work, and there's no benefit in either analgesia or procedure success with using it. Remifentanil has also been studied as an anesthetic option for ECV. A systematic review indicates that using remifentanil does increase the procedural success of ECV and reduces pain by about 2 points on a 0 to 10 scale, like down to 4.5 from about 6.5. But unfortunately, these benefits were not mirrored by a decrease in the rate of ultimate cesarean delivery, so kind of unclear why it seems to help procedural success, but then doesn't ultimately help more patients have a vaginal delivery after that. Neuraxial anesthesia has also been shown to increase success for ECV, and this is our standard anesthetic plan here at UVA. There are 4 main systematic reviews and meta-analyses on the use of Neuraxial for ECV. They were all published between 2010 and 2016, and they essentially all review the same studies. The 2016 paper just had one additional interim trial. So this is kind of a summary of the Neuraxial technique and dose, and then the control group for all of the studies included in these reviews. All of the trials used a tocolytic drug before the start of the ECV, which is something that should also help relax abdominal musculature and kind of prevent onset of contractions during the procedure. And all of the groups received some sort of IV hydration before the Neuraxial technique as well. Most of the control groups here were versus no anesthetic, although 2 included an IV opioid control group. And 2 of them involved epidural dosing up to a particular sensory level, but the rest utilized spinal anesthesia, ranging from low dose 2.5 milligram bupivacaine, which is similar to what we would put in combined spinal epidural for someone in labor, up to 9 milligrams of bupivacaine, and most of them did include adjuvant opioid. There was overall a 44% increased chance of success with Neuraxial anesthesia, so increased from about 40% to 60% success. Unlike the remifentanil studies, there was also a statistically significant increase in the rate of cephalic presentation in labor and of ultimate vaginal delivery compared to the controls. And importantly, these studies also supported the safety of utilizing Neuraxial anesthesia. So there was no difference in the Neuraxial compared to control groups of emergency cesarean delivery, placental abruption, transient fetal bradycardia, or other non-reassuring fetal tracing. A subgroup analysis from one of the meta-analyses suggested that higher dose anesthetic Neuraxial dosing increased ECV success to a greater extent than analgesic dosing, but this was based on kind of an indirect comparison of studies. The first randomized control trial to assess the dose response effect was by a group at Northwestern. This was published in 2017. They conducted a randomized double-blind trial to assess the effect of 4 different intrathecal bupivacaine doses, so 2.5, 5, 7.5, or 10 milligrams, with 15 micrograms of fentanyl on the success rate of ECV. There were 60 patients in each group, just 1 dropout in the 5 milligram group because their baby was found to be head down after they had already done the spinal. The primary outcome was ECV success, and then the secondary outcomes were ultimate mode of delivery, indication for cesarean delivery, hypotension requiring treatment, and the time to discharge. The overall ECV success rate, which is in the blue circles in the graph, was just over 50%, and there really was no difference with increasing doses of bupivacaine. There was also no difference in the rate of or the indication for cesarean delivery, which is the red squares on the graph. The emergency cesarean rate of 3.3% was also consistent between all 4 dose groups, though this was a bit higher than that 0.4% that was noted in the systematic review from the early 2000s that we had discussed earlier. The 7.5 and 10 milligram bupivacaine dose groups were about an hour slower to discharge compared to the 2.5 milligram group. I also wanted to point out that the higher dose group did reach slightly higher sensory levels, but even the low dose 2.5 milligram group achieved the T6 level needed for the procedure, and just under half of the 2.5 milligram group required any vasopressor, whereas 3/4 to 90% of the higher dose groups did. So this study really challenges that assumption that we need more local anesthetic to increase our likelihood of success for an ECV with spinal. The authors suggest that challenges with blinding in the other trials may have led to the greater observed difference in ECV success. Essentially that it's harder in a neuraxial versus control study. It's harder to fully blind the OBs to who had any kind of neuraxial versus not. And that may have kind of diminished subconscious bias by making it clear what group a patient was in, and that may be something that plays into the OB thinking that they're going to be successful because the patient's going to be more comfortable and trying harder, doing another attempt, versus this trial where because everyone got a spinal, it was less clear what group a patient was in. So what do we do with this? I think this is truthfully my least favorite procedure to do on OB, because every time I kind of go in circles again in my head that I do believe the Northwestern study that there's really no increased success rate with increasing doses of bupivacaine, and patients will get discharged faster. But there's always in the back of your head that what if we have an emergency C-section? For the majority of patients who are going to be discharged home, whether or not the procedure is successful, I think it's reasonable to do the 2.5 milligram dose of bupivacaine, since I see from the study it's not going to increase the chance of success. It decreases the chance of hypotension. And then I think it's reasonable to perform it in the labor room. This is the same dose we give for a labor CSE. And so that's something we commonly do in a labor room, not going to the OR for that. And so that saves OR resources. Some people might argue, oh, but if you have an emergency C-section, then you're not in the OR yet. But I heard someone argue a point once that I actually think makes sense to me, that perhaps the threshold to say we need to do a stat section is a little bit lower if you're already in the OR where you're going to do the procedure, and that you're less likely to call that if you're in the labor room, or maybe more conservative with what you do. There's also the element that by the time you take the patient, we see that a lot of these fetal decels should ultimately recover. And so perhaps even just the time of having to go from the labor room to the OR, and then you put baby back on the monitor before they splash prep the abdomen, and oh, look, baby's heart rate did recover. So I personally do feel comfortable doing the low dose spinal in the labor room instead of the OR. But that's sometimes we also do it in the OR, which is totally fine. I think it is reasonable to opt for higher dose for that margin of safety against a C-section. I think it's important to acknowledge that you're doing it because of that potential risk of C-section, as opposed to thinking that it's going to make it more likely that your procedure is successful. And I think it's critical that if you choose a higher dose, you realize that if you're doing effectively the same dose as you would for someone coming in for cesarean delivery, you need to expect the same sympathectomy and hemodynamic changes, and be really vigilant about prophylactically starting a vasopressor infusion and really promptly treating any hypotension, because I think there's otherwise the chance that we contribute like if we cause hypotension that can contribute to a fetal bradycardia that could cause the stat C-section we're trying to avoid. I think it's a little easier decision for the patients where the ECV is being followed by an immediate either cesarean delivery or induction of labor to do a combined spinal epidural where you utilize higher dose spinal to give you a dose sufficient for cesarean delivery if the ECV fails, but then you still have an epidural catheter in their back if it is successful, and you may not need to repeat an epidural procedure later in labor and just reactivate their epidural catheter. You also then have the epidural catheter to give morphine if you do end up having a C-section after. So to sum up some key points for ECV, I think we see that neuraxial block increases the success of rate of ECV, but it's still a little bit debatable of the optimal dose and neuraxial technique, and it's going to depend on a combination of institution and patient-specific considerations and kind of the way you're weighing the different pros and cons of each option. And just to really be mindful of the need for vasopressors with increased anesthetic local doses. Remifentanil provides analgesia and improves ECV success, so certainly can be an option for someone who either doesn't want or can't have a neuraxial technique, though the available evidence doesn't suggest an improvement in the ultimate rate of cesarean delivery. And unfortunately, the use of nitrous does not improve ECV success and is not something we should be considering. The last section we'll talk about here is postpartum sterilization. So female sterilization is fallopian tube ligation or removal, which is called salpingectomy. The latter is what's usually done these days for some ovarian cancer risk reduction with fully removing the tubes. Up to 20% of all females of reproductive age use sterilization as their contraceptive technique. So I think it's more common than we often realize. And postpartum sterilization is either performed, during a cesarean delivery right after closure of the hysterotomy, or via a mini laparotomy incision after a vaginal delivery. And that's really what we'll be discussing for the rest of this time, since the management of tubal during a C-section is just whatever you've done for the C-section. An ACOG committee opinion on access to postpartum sterilization reviews that this is a time point when it's technically feasible to achieve the sterilization through a mini laparotomy incision. The uterus is, much higher in the abdomen at the time of delivery, and then pretty rapidly within a few days involutes and descends back down into the pelvis, after which point you can't reach the tubes through that mini lap incision anymore. The patient's also already in the hospital and not having to coordinate time off or childcare, so it's a convenient time for them. And receiving a desired sterilization procedure is the best way to minimize the risk of future undesired pregnancy, which is why ACOG emphasizes the importance of attempting to complete requested procedures. There was a narrative article in 2018 in ANA that further promotes this relative urgency. And of course, we're never going to, in terms of the kind of urgency classifications of what we use for OR procedures, like it is elective, but just making this case that there's a relative urgency to it. They note that only a third to half of women desiring postpartum sterilization actually receive it during their delivery hospitalization. And the reasons that they don't end up receiving it are often related to OR, OB, or anesthesia availability, but also federal consent forms and Medicaid insured patients. So over half of pregnant patients have Medicaid for their insurance, and in order to receive postpartum sterilization, you need federal consent forms signed at least 30 days before the procedure and have them present at the time of delivery. And even if there's an unexpected preterm delivery, you still need 72 hours. So sometimes the timing of signing is something that makes it infeasible to do during the delivery hospitalization. Patients who don't receive their desired postpartum tubal have high rates of subsequent pregnancy. There was a one-year cohort study of postpartum women, and patients who requested but did not receive a postpartum tubal had an almost 50% rate of pregnancy within the following 12 months. And since they had all wanted a tubal, we can kind of assume most of those pregnancies were unintended, and that then is associated with increased maternal and neonatal morbidity, not to mention the cost of raising an additional child. And nowadays, with increasingly limited options for pregnancy termination if desired, kind of leaves patients in a suboptimal spot. So ASA and SOAP have some OB anesthesia practice guidelines, and those include a few comments on postpartum sterilization. They note that the timing of the procedure and the selection of your neuraxial versus general anesthesia should be based on anesthetic and obstetric risk and patient preference. Usually it's maternal complications like hemorrhage or infection that are the main factors that may prompt us to delay the timing of surgery. They affirm following ASA fasting guidelines, and if the case is going shortly after delivery, then the patient should already be on clear liquids only, but sometimes NPO status does become an issue once patients are on the postpartum floor, especially because the timing's often a moving target. A while back, there's a patient we were going to bring over, and then I went to go see her, and she was eating breakfast at the time, and there'd been like a miscommunication about whether she was going to have it, so that's not an uncommon story. They also note to not perform at a time when it might compromise L&D patient care. And I'd say this is commonly what causes delay here at UVA, where it's like, oh, we have this patient who's going to deliver soon, so the OBs are tied up, or we have a C-section in one of our 2 ORs and we want to leave one open for emergency, or we think we'll be going back with a C-section and therefore don't want to do the tubal. For our anesthetic technique, we have a higher likelihood of difficult airway at the end of labor, even compared to what we consider higher rate of difficult airway in a term pregnant patient. So that makes general anesthesia a less preferable option over neuraxial unless the procedure is occurring further out from the time of delivery. When we perform neuraxial, we need at or above a T6 level. There's less uterine manipulation than during a C-section, but still some, so you do need up to at least that level. During pregnancy, the gravid uterus causes intrathecal compression and epidural vein engorgement, and so that will lead to a higher dermatomal level for a given dose of local anesthetic. And so that is something that will change pretty much immediately upon delivery of the fetus. And also during pregnancy, progesterone causes increased tissue sensitivity to local anesthesia, and I wouldn't have thought that that could change so rapidly after delivery, but it really does seem to have a quick effect. And so we think about using equivalent or higher dosing as what we would have done for cesarean delivery. And multiple studies support the benefit of adding neuraxial morphine for improved post-op analgesia, though usually we would think about doing something a little bit less than what you would have done for a C-section with morphine. In terms of aspiration risk, delivery attenuates the anatomic displacement of the stomach by the gravid uterus, but you'll still have decreased lower esophageal sphincter tone and have delayed gastric emptying from labor, and right after delivery have airway swelling related to pushing. So there's not a strictly defined time frame of when you're back to kind of a baseline risk, and so this is a little bit of a moving target. I think a lot of people would feel comfortable that by 24 hours afterwards, you're probably close-ish back to a baseline risk, and that might be a time frame when you're more okay with some adjuvant sedation as opposed to saying that a failed block would necessitate converting to GA with a rapid sequence induction. So for our neuraxial options, we can either attempt to reactivate an existing labor epidural catheter or place a new spinal anesthetic. And if that fails, depending on the particular scenario and the timing, you could either repeat the block, supplement with local or sedation, or convert to general. And there was a recent survey on OB anesthesia practices. I'm not sure the numbers are probably too small to see, but basically there is pretty wide variation in anesthetic technique of how people go about this for tubal. I do want to highlight one recent retrospective cohort study from Stanford that included 300 consecutive patients who underwent a postpartum tubal and analyzed their anesthetic management and block failure rates for each anesthetic technique. Almost 2/3 of their patients received a de novo spinal anesthetic with a 15% failure rate. Just over 1/3 of patients had their labor epidural catheter reactivated, and 1/3 of those failed. And of the subset of patients who had failed initial neuraxial and a block repeated, 1/4 of those still failed. And this was in comparison to 100 contemporaneous patients undergoing for cesarean delivery at that same institution, and those patients had a 4% failure rate. So all of these were much higher than that, and I personally felt like 15% was way higher than I would have expected for a fresh spinal anesthetic. They did not find any association with drug dosage for either the epidural group or the spinal group, time since epidural catheter placement or time from delivery to the tubal, or the need for supplemental top-up doses in labor. These are factors that earlier studies had tied to an increased risk for failed epidural reactivation. In the failed block groups, the time to incision and the total OR time was significantly increased, but this presumably was more so related to the anesthesia team managing a failed anesthetic as opposed to it actually being a big difference in the surgical time itself. So I thought it was really surprising how high the failure rate was even with a spinal anesthetic, and the doses they used for epidural reactivation were at least as much, if not more, than what we typically need to use for a cesarean delivery, and their bupivacaine average dosing of 10.5 milligrams or 1.4 cc's of the heavy bupi, is a little bit less than what we typically use here for a C-section, but still a very reasonable dose that many places would use for a C-section. And it's just surprising that we see such different results for the postpartum tubal. This is really consistent, though, with other institutions' findings from retrospective studies with about a 1/3 failure rate of epidural reactivation and up to a 20% failure rate of spinal anesthesia. There aren't any prospective studies that I know of looking at this, and I think it certainly is something that's made me think it'd be worth looking at our own data. We don't end up doing these procedures too often, but still it's something that we should work to optimize. So overall, our failure of epidural reactivation is greater than doing a de novo spinal, although even that is still higher than ideal. So I still think this would support having a very low threshold to pull an epidural catheter and replace it with a spinal, especially if you've had any issues with it during labor. For either epidural or spinal anesthesia, I would at least use an equivalent or higher dose of local anesthetic than for a cesarean delivery. And I think for sure adding fentanyl, since that's always going to get you better quality of your block for whatever dose of local you're using. And consider doing general endotracheal anesthesia with a rapid sequence induction if you have a failed spinal less than 24 hours postpartum, but perhaps later time points you'd be okay for a little bit of sedation if you're mostly okay with the block, but just need something a little extra. And do think about adding some epidural morphine. That is all I have. Thank you, guys. Any questions? Sunny?
So if you're going to be adding morphine to that spinal, that could hold up their discharge because they do need to have a 4-hour period of observation. So sometimes it could be appropriate, but I also think that maybe there are others that would delay.
That's a great point. So for anyone on Zoom, Dr. Chow was mentioning that because if the tubal is done at a later time point where that's like right before delivery, giving epidural or spinal morphine would mean they need to be monitored for 24 hours before discharge. So perhaps consider omitting it if that would become a barrier to discharge for patients. Anything else, Geyer? Well, this would be not the patients, but the fetuses. I admittedly don't know the exact logistics involved in them assessing this metric. which would be having a cesarean delivery, though you're still not going to have a 0% rate of perinatal mortality in any form of delivery. I guess that's a good point that it would be worth assessing the corresponding mortality risk in patients who have a breech fetus and don't undergo an ECB. But this was just a systematic review. Patrick?
If you had a patient have a comfortable epidural through their labor, would your practice be to attempt to boost up the labor epidural cerclage, say, give a couple doses in the labor room or in triage before heading back to the OR, and if it's not working, then sit them up in the OR, pull it, and do the spinal?
Yeah, so I think for me, depending on the time frame of when we're going to go for the tubal and how well that epidural had worked for a patient in labor would be my threshold to decide whether I'm going to pull it or attempt to activate it. I certainly think if it ends up being something where we're doing the tubal before they've even gone over to the postpartum floor and their epidural worked well in labor, then it's definitely reasonable to start topping it up. I tend to be more leery if it's been, they've been on the postpartum floor for hours. Often we end up pulling the catheter before they go over anyways. I think just things end up being in such flux of when the procedure would happen, that's usually how I would go about it. And of course, if someone had a really challenging epidural placement or something, or they were really resistant to the idea of needing to undergo a repeat spinal and wanted to attempt the epidural reactivation, I think it's reasonable. We just would need to try and call it on the earlier side, similar to a C-section, where if you've given like 10 mLs of your 2% Lido epi bicarb and you're not getting somewhere with that, then I would pull it and replace. Right. Thank you guys. Have a great day.